France's healthcare system regularly outperforms Canada's system. So today we're in France to try and learn what Canada should be copying from the French model. I'm Colin from secondstreet.org.
And I'm Renaud Brossard from the Montreal Economic Institute.
Let's go see. Like Canada, France has a universal healthcare system that covers all French citizens. The government uses tax dollars to cover about 77% of healthcare costs in the country. This means that if a French citizen needs to visit a family doctor, or needs something like knee replacement surgery, almost the entire bill is paid for by the government with tax dollars. For the remainder of the bill, 95% of French citizens have insurance. Insurance fees are paid for by patients and their employers. Low-income patients who are unable to afford insurance have the entire cost of their health services fully paid for by the government. Ultimately, this means that French patients do not face massive bills when they need health services.
While no healthcare system is perfect, the French system is quite respected in the world. It uses a variety of health providers to provide care. There are government facilities, non-profit facilities, and private facilities. This mix helps create a competitive, innovative environment. Research from the Commonwealth Fund shows that nearly 1 in 2 Canadian patients reported finding it very difficult to access medical care after hours without resorting to an emergency room visit. In France, that proportion is less than 1 in 4 patients. The same goes for surgery, whereas nearly 60% of Canadians reported having to wait over 2 months for elective surgery. Only 1/3 of French patients reported having to wait that long.
Henri Leloup is a doctor and public health expert who co-founded the think tank, Public Health Expertise.
The basic idea in France is we have public insurances, so both public and private are reimbursed for the care they have. So the basic idea is that the system is the same for both public and private hospitals.
Leloup told us about private insurance that French citizens purchase along with their employers.
Nowadays, employers have an obligation to pay for part of it, at least 50% of the complementary insurance plans. They are pretty cheap in terms of health insurance standard. They're more around the €100 per month.
Nicolas Bouzou is a French economist and essay writer with Asteres, a French think tank.
Both public and private hospitals are highly regulated. But to put it simply, I'd say private hospitals have a bit more flexibility, with slightly less regulation than public hospitals. This allows them to take more initiatives and to act more quickly. For example, if you need to purchase a machine for imaging or a robot for surgery, the process is very lengthy and highly complicated in the public sector, whereas decisions can be made relatively quickly in the private sector. That's a key organizational difference. However, I can tell you, because it's documented, private hospitals are better managed than public hospitals. The costs and productivity are more optimized in the private sector compared to the public sector.
In France, patients don't have to worry about who is running the hospital they visit. Patients choose the hospital that they think can best help them, and then the government gives money to the hospital based on the services provided to the patient. This is known as activity-based funding. For example, if a patient needs knee replacement surgery, the government may pay, say, €14,000 for it. It doesn't matter if a patient chooses to have the procedure done at a government facility, a private facility, or a non-profit facility. The €14,000 follows the patient. This helps incentivize hospitals to help more patients because each time they help a patient, they get more money. Lots of better performing health systems in Europe and around the world also use this funding model.
In Canada, the government takes a very different approach. It uses an older funding model known as block funding. Each year, most governments send a large check to a hospital and then hope that the hospital helps a lot of patients. Canadian model does not incentivize hospitals to increase output. This approach also restricts innovation as hospitals have less freedom and less incentive to change their practices to help patients.
Mais grosso modo, en effet.
In France, when someone has an appendectomy or a hernia operation, the remuneration is fee for service. And yes, it seems clear to me that this competition between the public and the private sectors forces the public to improve certain things, notably to improve the quality of reception and to improve productivity, and to make progress in certain areas such as outpatient surgery.
What this data shows overall is that, in terms of overall satisfaction, the difference isn't very significant. Satisfaction is better in the private sector, paradoxically more so in the non-profit private sector. Overall, the private sector excels in amenities such as rooms and food services. In France, the public sector suffers from a lack of investment in amenities. Providing a nice room is not really part of the public sector's culture.
Lele noted that while the private sector is generally more efficient at common procedures like hip or hernia surgeries, he believes government health facilities are better at handling rare procedures.
Private hospitals play a very important role in France in terms of volume. For example, 75% of outpatient surgery is done in private hospitals in France. So they represent a significant volume in terms of activity. For many activities, they represent almost half of the sessions, such as dialysis or chemotherapy. They account for a large part of psychiatric hospitalizations and a significant portion of rehabilitation and follow-up care. So they have a substantial volume of activity in France.
Philippe Juvin is a doctor and member of the National Assembly in France, which would be their equivalent of our House of Commons.
I believe in the absolute necessity of having public services that work, but even more so, public services that work well. And in a way, it doesn't matter who provides the service, whether it's a civil servant or not. What matters is the service is delivered to the public. And I believe private operators can provide a public service. Complementarity is a very good thing. It allows for a little competition, which means that professionals can easily move between the public and the private sectors. It's all based on a different way of operating. There is everything to be gained from complementarity. Smart people invent what they need. The worst is when the state decides what public and private sectors should do. I believe in letting people decide horizontally.
So we actually find that sometimes in Canada, don't we, where someone will go for an X-ray or maybe a blood test or whatever, and it's actually done in a private facility, but when they leave, that facility bills the government, and the government pays the bill, and the patient's happy.
Yeah.
One of the things that I was thinking about actually is that in British Columbia, there's some cases where there's some privately owned MRI machines that are often sitting unused because the government will not contract those clinics to provide care to patients in the public system. They don't want to work with them. But I don't think we'd find that here, would we?
No, I don't think we'd find that either. And a lot of doctors mentioned that there's a complementarity between the different models. You know, there's the for-profit model, the not-for-profit model, and the public model, but they all work as part of the same healthcare system, and they're all covered in the same way at the same cost by the same universal insurance. But the next thing that'll be really interesting to see is how those private, for-profit, and not-for-profit clinics and hospitals actually operate, like how it works, and how they actually make it work for them, but also for the patient.
Julie Chastre is the general manager of the Saint-Camille Hospital, a not-for-profit hospital in the suburbs of Paris.
Non-profit hospitals are often created by mutual societies or religious congregations. So these are often older hospitals. We have a board of directors that organizes the hospital strategy, with, of course, a management team at the helm, and a hospital community that manages it under private law. We apply labor law to our healthcare professionals. The major difference is often the size. Most of our associations are on a human scale. They are hospitals that are well established in their territory and which, in most cases, meet local needs. Although some establishments have regional, national, or international reputations, they generally fulfill an immediate need and are therefore medium-sized. Unlike public hospitals, which are often the result of local mergers and therefore much larger, which means there is often a level of administrative red tape that we do not have.
It was interesting to hear Chastre describe how public, private, and non-profit health facilities in France all work together and have friendly relationships.
They are often complementary. Most associative institutions, as I mentioned, are well integrated into their territories, so we have agreements with either for-profit institutions or public institutions. Generally, we maintain very good relationships. Once again, we are not in direct competition. Instead, we integrate well into the hospital landscape. Non-profit private hospitals operate on the same funding model as public institutions. We advocate for this system. We are funded based on activity, known in France as activity-based funding, just like public hospitals. We also receive specific funding for public service missions, such as emergency care, continuous care, palliative care, and support for social vulnerability. We have dedicated funding that is at the same level that public institutions receive.
Christine Schibler is the executive director of the Federation of Private Hospitals in France.
When a patient goes to the public or private sector, they have billing. Health insurance covers most of the billing. The patient does not see this exchange between health insurance and the establishment. They won't realize that it costs more in the public sector than in the private sector. We are much cheaper in the private sector. For pathologies, let's say in medicine, surgery, and obstetrics, we're on average 20% cheaper than in the public sector. The private sector also performs significantly better in terms of waiting times, whether for-profit hospitals or non-profit private hospitals. This is certain. Previously, we told you that we did 35% of the hospital activity in France. However, we only account for 18% of the budget.
Dr. Xavier Poble is an emergency physician in charge of the Saint Etienne Immediate Care Center. This privately run emergency room model helps patients with less acute medical emergencies that don't require all the equipment from a traditional hospital emergency room, such as a broken arm, for instance. It is owned by the doctors and nurses who work there. We asked them about this model and how it compares with hospitals.
These centers have been around for 5 to 6 years now. Ours opened in 2019, so we are coming into our 5th operational year. We've gone from 0 visits at the start to a bit over 42,000 visits last year. So broadly, a classic emergency center that handles all age groups and pathologies in our region sees between 35,000 and 45,000 visits per year. We actually handle as many visits as a public hospital emergency department. We only receive the consultation and procedure fees set by the French health insurance, which determines the reimbursement rate for procedures. Therefore, we can only be paid through these regulated fees.
On ne touche exclusivement et de manière catégorique que le remboursement de notre activité pure, conventionnée et donc par rapport à...
In contrast, the hospital emergency department functions with 2 different types of financing called T2A, which is purely activity-based funding, and an additional financing known as FAU, which is a flat rate based on the number of visits.
On appelle ce qu'on appelle un FAU, un forfait, qui est un forfait au nombre de passages.
It's a global allocation based on the activity of a service. To put it simply, we have conducted several studies within our Federation of Unscheduled Care Centers, which show that in an unscheduled care center, for a similar patient with an identical pathology, it costs between 5 and 8 times less than a hospital emergency department for the same type of pathology.
So one statistic I found to be really mind-boggling is the fact that private hospitals provide 35% of the care, but only costs 18% of the budget. Like, as a taxpayer, that's a great deal. And it goes to show the sort of efficiency that these independent establishments are incentivized to get in this sort of model.
Well, for sure. And, you know, Renaud, it reminds me because last year we were in Sweden and we toured a private hospital there that was located just a few kilometers from a government-run hospital. And they had to provide the same level of care, but the private one was getting the job done for a lower cost. And so when they did that, those savings could then be used to provide even more services for patients.
And that really goes to show the power of activity-based funding. You know, it's this funding model where the government will provide a set amount of money for specific procedures, and that money is going to follow the patient to the establishment where they choose to get the care they need. Now, that creates a sort of friendly competition between the different hospitals to try and attract the patient, but also enables doctors to essentially set up their own shop, find their own way to solve some issues. Like when we were talking with Dr. Poble in Saint-Etienne, well, he saw that the local hospital had very long wait times at the emergency room. So he set up an emergency ward that essentially covers minor emergencies, but does so at a much more cost-effective, in a much more cost-effective manner. And makes people wait, well, only a fraction of the time they would have waited otherwise.
And the next thing we're going to explore is related to that, and that's sort of how the two systems can share information, share ideas, learn from each other so that they can ultimately deliver better care for patients.
The efficiency of the private sector has pushed public hospitals to also become more efficient, effective, and better organized, because they are in competition on certain standardized activities, whether it be outpatient services, ankle or knee prosthetics. These kinds of activities are profitable enough, and there is enough competition between the public and private that it has quite a virtuous effect. However, the autonomy of management in private hospitals allows for the optimization of certain aspects of care. There is generally better organization, more efficient waiting lists, and the ability to handle higher patient volume.
For example, ambulatory surgery is performed in 65% of private establishments in France, and it was developed across all establishments under the impetus of the private sector. Similarly, robot-assisted surgery was first developed in the private sector before being adopted by the public sector.
There is one example that is often cited and is real. I visited it. It is the Valenciennes Hospital. Valenciennes is a city in northern France, in an economically disadvantaged area with a low-income population. There is a public hospital that, about 15 years ago, was suffering from significant deficits, recruitment difficulties, and with low-quality care. Then a director arrived about 15 years ago who decided that the hospital would operate according to principles of autonomy for its departments. He divided the hospital into departments by activity, and each doctor had financial autonomy within their department, which does not exist elsewhere. It's a delegation of management from the director to the heads of the department, but a real delegation in both revenue and expenditure. This autonomy seems to have borne significant fruit since the hospital has modernized and no longer faces the deficits of 15 years ago. The quality of care is very good. But yes, Valenciennes Hospital shows that private sector practices can work. In fact, the recipe is always the same: autonomy. Raymond Aron, the great liberal philosopher, said, "Prosperous societies are those where individuals can freely express their potential." I believe strongly in freedom. When you give people freedom, they use it intelligently. That's what happened in Valenciennes.
We decided to travel to Valenciennes to learn more about what lessons Canadian hospitals could learn from France's well-run government hospitals. Its staff noted right away the importance of granting autonomy to personnel so that good ideas could be acted on quickly by grassroots employees.
In 2008, the budget was approximately 250 million euros, and there was a persistent deficit with no prospects for improvement. The idea was to create new perspectives by delegating decision-making closer to the ground and fostering a culture where practitioners and teams embrace the dynamic of financing in institutions. This approach, combined with a trusting relationship between actors, allowed us to overcome our objectives and break the cycle of deficit. The logic at the time enabled us, 15 years later, to have an institution that continues to thrive, which has experienced structural surpluses, and which continues to experience cyclical surpluses. It's a functioning model that has trusted all actors, whether administrative, technical, medical, pharmacists, or care staff, regardless of their professional category. This context is crucial.
Overall, it maintains a very collaborative approach with private health providers in the region.
For private for-profit establishments, we have connections, because sometimes patients are taken care of by the Valenciennes Hospital Center during emergency care when other actors may be lacking. There can be cooperative projects between us. But the goal is to maintain a strong public sector strategy
public qui fonctionne bien, avec une stratégie de groupe public,
while complementing with private offerings. This gives patients the choice to be treated in a public institution like ours or in a private facility, with quality often being the determining factor between coming to see us or going somewhere else.
Qui va souvent dicter le fait de venir chez nous ou d'aller dans un autre établissement.
And that was a great story from Valenciennes, and you can see that this public hospital clearly learned some lessons from the way that other hospitals are managed, and this friendly competition between the public, the private, and the not-for-profit sector has enabled them to do better for the benefit of the patient, essentially.
Yeah, and one of the examples I loved when we toured that facility was how in that one room you could see was the surgical recovery room where they removed all the walls.
Right.
And that was an idea that they had at the grassroots level there. The staff figured out that, hey, wait a second, if we took these walls out, then staff could watch more patients at once. It was more efficient. And we see that type of change happening in other areas of government reform, where when you unleash that ability of people on the front lines to come forward with ideas and affect their environment, they often know exactly what needs to be done. You just need to tweak the incentive model to gain those types of efficiencies, and that's what they've done here.
And you know, that's one system of management that's much closer to how the independent hospitals operate. Because when you get a good idea on the ground, it doesn't have to go all the way up to the minister in order to get implemented. At a much more human scale, you can more easily have that sort of input from the staff on the ground to the management. But ultimately, the one thing that really stands out about this system is that it's not focused on ideology. It's not focused on protecting the public aspect. It's rather focused on giving patients the service they need in a timely manner with the best quality possible. And that's really what stood out for me throughout this trip.
Mm-hmm. I totally agree. That's a great note to end it on. And if you're interested in learning more about health reform, you can visit both of our websites, secondstreet.org and
edm.org.
Thanks for watching.